Now let's get this party started. We'll start with our very own Dr. Weinberg. She's a non-invasive cardiologist with a passion for prevention. She lectures on various aspects of cardiovascular disease, the leading cause of death worldwide, and ways to prevent it. This year has challenged our understanding of mortality, and so she's going to kick things off with a case-based talk on questions to ask your doctor to help you stay forever young.
Good morning, everyone. My name is Nicole Weinberg. I am a non-invasive cardiologist at Pacific Heart Institute in Santa Monica, California. I'm going to be kicking things off today with a talk entitled 5 Things to Ask at Your Doctor's Office to Stay Forever Young. So let's get started. So case 1. So we have a 59-year-old female who eats healthfully, exercises regularly, but wants to make sure that she stays forever young. She asked her doctor for everything at her upcoming physical. Where should she begin? So we're going to talk about this case as it relates to 3 different bullet points: basic blood work, advanced lipid testing, and lipoprotein(a). So for basic blood work, the doctor generally checks things like your liver panel, your blood counts, your electrolytes, your kidney function. Additionally, your basic cholesterol can be included, and that generally includes things like your low density lipoprotein, or your LDL, which is your bad cholesterol, your HDL, or your high density lipoprotein, or your triglycerides. These are all considered basic cholesterol blood work that can be checked at your doctor's office. The American Society of Pediatrics generally recommends starting screening testing of cholesterol between ages 9 and 11 years old, but most adults get this checked annually at their checks in the doctor's office with their physical. So if we think about advanced lipid testing, that's taking the basic cholesterol a step further. That's looking at the LDL cholesterol, stripping the membrane of the LDL, and looking more deeply inside the LDL cholesterol. You're looking at the particles that make up the LDL and understanding where this puts you in your risk profile. So if you look at the patients on this page, there's 4 people shown. They all have an LDL of 125, but you can see the ones that have less particles on the left side of the image don't have as high of a risk, but the ones that have a higher risk have more particles, so the one on the right side of the page. So that person has a higher likelihood of having a cardiovascular event. So advanced lipid testing is not new. It's something that's been around for decades, and there have been over 2,000 systematic reviews looking at risks of cardiovascular outcomes, heart attack, stroke, and death, and these LDL subfractions, or this advanced lipid testing, to be able to understand what will yield a better result for our patients. And we have found that the advanced lipid testing gives us much more information than basic lipid testing alone. So if we take that advanced lipid testing a step further and we look at lipoprotein(a), we consider this to be an independent risk factor of cardiovascular disease. So if you think about cardiovascular disease as a pie, there are a lot of pieces of the pie. There's whether you have family history, high blood pressure, high cholesterol, diabetes, if you're a smoker. Well, lipoprotein(a) is yet another slice of that pie. It tells us if you have this independent risk factor that is a pro-inflammatory agent. And so if you have this, you have increased risks of developing plaque in your coronary arteries. You also have increased risks of developing aortic stenosis, or calcification of that aortic valve. So if you have elevated levels of your lipoprotein(a), you are between 2 and 4 times greater risk of having premature heart disease, heart attack, stroke, and aortic stenosis. So those levels, as measured in the blood, are greater than 50 milligrams per deciliter. So if you have a number in your blood of greater than 50, you are 70% more likely to develop coronary artery disease. So because these numbers are so high, this is now considered to be a malignant risk factor of coronary artery disease. So it's important to identify it in our high-risk patients and then ultimately decide how we want to manage them further. This should be checked in patients that have a significant family history. So men that have a family history of somebody in their family having a heart attack, stroke, or death younger than 50, and in women younger than 60. So these are patients that may have perfectly normal weight, blood sugars are completely normal, blood pressure and basic cholesterol numbers are normal, but they will still have an increased cardiovascular risk if they have an elevated lipoprotein little a. So in terms of treatments, so this is where there's a lot of research going on. As of right now, there are no good therapies, but there are some medications and supplements that can lower the lipoprotein little a, although minorly. Things like niacin and the new injectable cholesterol medications like the PCSK9 agent can lower your lipoprotein little a. A lot of the research right now is looking at whether you actually lower it in your blood. Are you improving cardiovascular outcomes? So are you lowering the patient's risk of having a heart attack, stroke, or death? Right now, the jury is out. We do not have good data to support lowering the lipoprotein little a, but what we do have is good data to support lowering all the other risk factors to quite low levels, such that we reduce the likelihood of progression of disease from those other pieces of the pie. So in conclusion, it's very important for you to know your risk factors of disease, and this can be found out through simple blood work. You also want to have your lipoprotein particle number or your lipoprotein little a checked for patients that have a significant family history of cardiovascular disease. And the treatment options are in development for lipoprotein little a, but we do know that lowering your risk factors, including lowering your LDL, seems to be the mainstay of treatment at this time. So now that we've gotten through case number one, let's move on to case number two. This patient is a 51-year-old female who expresses great concern about her family history of heart disease. She knows that every year when she goes for her physical, her blood work is fine, her blood pressure is fine, her exam is normal, everything is great, but she wants to live forever. So what should she ask her doctor for? So we're going to break this case down into three different topics: heart disease statistics, coronary artery disease testing, and the coronary calcium score. So I know we have shown this slide probably every single year, but it's important to just hit home with our basic theme, which is heart disease is a leading cause of death. It is still the #1 leading cause of death in women. It kills more people than number 2, 3, and 4 combined, which are stroke, lung cancer, and COPD, all combined. And if you look at this #1 leading cause of death, about 50% of the deaths are related to coronary artery disease. So it's really important that we identify patients with coronary artery disease. If you look at our guidelines within the world of cardiology, there are no screening tests that we use to be able to assess for which patients are at increased risk. Most of what we do is related to stress testing as it relates to coronary artery disease. And so it's important to identify our patients. Now, if we look at stress testing, what are you getting out of a stress test? Well, a stress test is looking for blockages in your heart arteries that are considered to be significant. So blockage 70% or greater is what we consider to be significant. That's because there are flow changes and different features of a stress test and your body's own chemistries that we can check for that will tell us that this blockage is something significant and requires intervention. If you have a normal stress test, you could still have a blockage that's 60%. And that's something that a lot of my patients would like to know. They're not going to get that from a basic stress test. So if we look at coronary artery disease testing, there are different types of tests that we look for. So stress testing is one, and the coronary calcium score is another. If we look at stress testing, it's a great study because it's a functional test. So we can see what your body looks like with exertion. It's wonderful if you're having some symptoms and there's some concern that those could be related to blocked heart arteries. We can also do this study without any radiation, much of the time on the treadmill or with the echocardiogram machine. If you're having a nuclear stress test, there is a small amount of radiation associated with that type of stress test. With these tests, we're looking for blockages, like I said before, that are 70% or greater, something that's considered to be clinically significant that may require angioplasty or a stent placed and or bypass surgery. If your stress test is normal, the likelihood of you having a heart attack or sudden death related to blocked heart artery puts you in a low risk category for 2 years after your test. So it's all good information, but there might be more. So a coronary calcium score. So this is not a functional test. This is a CAT scan study. So you're not exercising, you're lying on a table and you're going through the CAT scan machine. There's a small amount of radiation associated with this. It's generally equivalent to if you got on an airplane and flew to Las Vegas. But it does tell us if there's plaque buildup in the system. And this is generally why people want to get the study. They want to know if they are depositing plaque. If your coronary calcium score is 0, that means you have no plaque buildup in your system. It means the likelihood of you having a heart attack or sudden death related to blocked heart arteries puts you in a low risk category for 10 years. So that's wonderful if you think about the likelihood and predictive value of screening testing versus a stress test. So a coronary calcium score is something that we are utilizing more and more as it relates to getting this good information from a screening perspective for our patients that are at increased risk of cardiovascular disease. It looks for any plaque buildup. It doesn't just say, oh, your stress test is normal, so we'll see you again in 1 to 2 years. It actually identifies people that are at risk despite how healthy they feel or what their risk factors may show. The only issue associated with this study that is not optimal is that many insurance companies don't pay for this out of pocket. And so it does require an out-of-pocket expense for some of our patients. This out-of-pocket expense in our area is generally less than $200. So it's significant, but most of the time the doctor's office or the radiology center will be able to give you that information before you have the study. So this is what a coronary calcium score looks like. If you look at the picture on the left side, you will see that that's a patient with a coronary calcium score of 0. So we look for white spots in the gray around the middle. The white on this study is rib cage on the sides and spine at the bottom. And you can see that there's no white spots like that in the middle of the gray matter in the middle of that picture. If you look at the slide next to this, this is the same patient 15 years later with plaque buildup. And so you can see that within this gray matter in the middle, you do have some white streaks in there. That bright white is similar in brightness to the spine at the back and the ribs on the side. So that's how you can appreciate that this person has calcification noted in their heart arteries. So what do you do with this information? Well, you get a score with your coronary calcium score, and we use that as a means of risk stratification. So again, if you have a 0 coronary calcium score, we know that you have no hard plaque. But if you have a score of 0 to 100, we assume you generally have minimal to mild plaquing in your heart arteries. And greater than 100, we generally consider that to be something that may be clinically significant. And depending on risk factors and different symptomatology, these positive studies may warrant further testing. The other thing that's really interesting about this report is it gives you a percentile risk. So it takes you as the patient and compares you to other people that are your same gender in your same age group. And so it's sometimes nice to see where you stand compared to the other patients in your age group and your gender. If you are greater than the 50th percentile, that's generally not optimal. And we always are looking for ways to reduce that risk moving forward. So let's say you have a coronary calcium score and it's elevated. You may ask, are there other things out there that can elevate my coronary calcium score? Well, generally, when we look at patients that have an elevated coronary calcium score, 90% of the patients that we look at that have elevations, we generally blame it on the cholesterol levels, the inflammatory risk factors, and some of the things that we've discussed already. But there are a few other things that are interesting that are being looked at in the literature. So one has to do with radiation. And if you think about our treatments for, say, breast cancer, for example, there is radiation to the chest wall, and beneath the chest wall is the heart. So it's not unusual to think that there may be some radiation that hits the heart arteries, the aorta, the valves from these treatments. And it generally doesn't happen right away, but there is a buildup of some irritation to the cells that are hit by radiation. And you can see some of these changes at about 10 years. Radiation therapies have gotten much better over the years, and many of them are much more targeted. So this is something that we follow very closely with our patients, but not to worry or decide that you wouldn't have radiation therapy based on this. A lot of the therapies are much improved compared to where they used to be. Additionally, there are things like environmental toxins. We had spoken a few years ago about particulate matter in the air and how this can have an inflammatory effect within our bodies, particularly our heart arteries. Additionally, smoking has similar particulate matter that has a harsh oxidative property and can cause deposits of plaquing, irritation, and lots of inflammation. And lastly, and this is a category that is very much studied at this time, are patients that do significant anaerobic exercise. If you look at patients that are ultramarathoners or exercise for miles a week by running, they are depositing plaquing in their arteries at a rapid rate. This is something that is being studied quite significantly because the leading cause of death in this generally thought of as healthy patient population is cardiovascular disease. So in conclusion, heart disease is the leading cause of death, and that should be the take-home message. Looking at stress testing is a great test, but it is really significant if you're looking for blockages in your heart arteries. A coronary calcium score is something that may yield additional information because it'll tell you if there is any hard plaque buildup in your arteries that may need to be treated. So moving on to case number 3, we have a 48-year-old female who presents to the doctor's office with concerns that she is turning into her mother. Her exam is normal, her testing is good, but on closer examination, her glucose and triglycerides are higher than they used to be. How can she stay forever young? So in this case, we're going to talk about metabolic syndrome. Why is sugar bad? Recommendations for diet and exercise based on the American Heart Association. So metabolic syndrome. So this is a defined disease process that includes a glucose that's greater than 100 milligrams per deciliter, an increased waist circumference of 35 inches in women, elevated triglycerides greater than 150 milligrams per deciliter, and an elevated blood pressure greater than 130 over 80 millimeters of mercury. So why is it significant to identify these patients? Well, about 20 to 30% of the population in industrialized countries has metabolic syndrome. It has a very strong genetic predisposition, but once you identify patients with this, it's very important to modify their risk factors because they have a 2 to 4 times greater likelihood of having cardiovascular disease than the normal patient population. Generally, a lot of these changes start around perimenopause as some of the hormone levels drop, and those 10 years after menopause starts are when women's bodies change and their risk factors for cardiovascular disease generally become a bit more significant and apparent, and that's oftentimes when we start to modify their risk factors. This is one of the times when checking triglycerides, especially in women, becomes very important. Triglycerides in women are considered to be an independent risk factor in light of this very finding related to metabolic syndrome. So for the purposes of my talk, we're going to talk about how diet and exercise can help metabolic syndrome, which is not something that can be underestimated as to the significance of it. Later on in this meeting, Dr. Wright will talk about some interesting pharmacologic updates as it relates to blood sugar, diabetes, and heart disease. So in the world of the American Heart Association and cardiovascular disease, a lot of what we end up recommending for patients is the Mediterranean diet. So this is a diet inspired by eating habits in Spain, Italy, and Greece from the 1960s. A lot of it has to do with ingesting high good fats like olive oil. There are great studies about how much fish the Mediterranean diet includes. There are wonderful studies about getting protein from plant-based sources like beans and legumes. And these are the reasons why the Mediterranean diet has been so popular within the world of preventative cardiology health. You will notice on this pyramid that meats are very at the top of the pyramid, so those are less often, as are sweets, and wine is on the side as listed in moderation. So just to kind of talk about sweets and why they are so bad has to do with the feedback loops associated with this. So if you look at our patients that are eating about 15% of their calories from sugar, they have a 40% greater likelihood of having cardiovascular disease. So you think about everything that you eat in the day and how it gets broken down in your system. 15% of your calories is actually not that much, but to increase your risks of having a cardiovascular event by 40% is very significant. We're learning more and more as it relates to sugar that things are on a bit of a feedback loop, and there are addictive properties to having sugar. So if you're somebody who maybe likes to have a meal with sweet afterwards, every day you may want that sweet at the same time after your meal because it's something that you're craving. There are a lot of interesting studies looking at the neurochemistry associated with the body when it has sugar and equating it at a smaller magnitude, but to similar responses to drugs of abuse like cocaine or morphine. So it's important to check in with your body and say, okay, why do I want this? Do I need it? Am I still hungry? What is this, just that I want this because I had it yesterday at the same time? So that's some of the mechanisms as it relates to understanding why sugar is not so good for our system. Additionally, if we look at the alcohol piece of the puzzle, this is something that I have heard a lot from patients over the past year, that they have been drinking more, and it is something that is a stress relief. It is something that they are doing to manage their day. It's not just for social purposes like it used to be on Saturday and Friday nights. Now it may be most days of the work week. So if you look at the American Heart Disease guidelines recommending sugar in women, you can see that women are recommended to have 25 grams of sugar or 6 teaspoons of sugar during the course of the day. From my perspective, that sounds quite minimal, but if you look at where that lies as it relates to your alcohol, it can be chewed up quite quickly if you're having a few beers or a few glasses of wine at night. So if we look at the slide detailing the beer, if you have a bottle of Heineken, that's 2 teaspoons of sugar. Many people end up maybe having more than 1 bottle of beer. And so that may be something that could completely eat up what you are allotted for your sugar during the course of the day. Wines are a little bit of a different story. Sweeter wines obviously will have more sugars in them. So a sweet wine will have about 2.5 teaspoons of sugar. A white wine will have about 1/4 teaspoon of sugar. And that, along with a few other healthful properties, is why the Mediterranean diet generally advocates for choosing red wine over some of these other alcohol substances. But let's just say every night you're having 2 to 3 glasses of red wine at the end of the day to unwind. So that may be close to a teaspoon of sugar at the very end of the day. And it's something that may actually be clinically significant as it relates to weight changes, glucose changes, blood pressure changes, and cholesterol changes. So why do we need sugar? Well, the breakdown of sugar from carbohydrates gives us energy. So these are the things that we use to run and exercise and perform our activities. So please do not underestimate the significance of getting this in your system. Our bodies need carbs and they do need sugar. But let's just say, for example, you're looking at an athlete who is getting ready for a race and they're training for this and they're eating more carbs because they're burning it when they're exercising. That's something that seems like they're using their food as fuel and they're using that to complete their exercise. If you think about how maybe we could be using our alcohol at the end of the day, we're probably not fueling very much exercise or activity. It's something that we're just drinking and sitting and relaxing. And so it's something that I don't think should necessarily be taken out of your diet, but I think it's something that we need to understand the significance of and decide, is this something that I need at this level? As it relates to exercise, just to segue a little bit, the American Heart Association's recommendations for exercise are not complicated. They're saying you should go for a walk about 30 minutes a day for 5 days a week. That is as minimal as you can do, and it does go up from there. You can do more high intensity exercise. all of this exercise is very good for reducing your weight, reducing your blood sugars, reducing your blood pressure, reducing your cholesterol. So again, the American Heart Association does not make it very complicated. Walking every day is very healthy, and also hearkening back to some of the food issues and the blood sugars and the breakdown. I have heard from a lot of people that the recommendations that their dietitians have given them and their endocrinologists are to walk after a meal, because then you're breaking down some of those carbohydrates and sugars that you've just ingested. So in conclusion, metabolic syndrome is a significant risk factor for cardiovascular disease. Be mindful of your sugar intake, including portion control, food choices, and alcohol. And please do not underestimate the importance of diet and exercise to maintain your overall health. So case 4. So we have our 62-year-old female who feels like she cannot get a good night's sleep. She wants to wake up rejuvenated, but instead wakes up feeling groggy. How can she fix this so that she can stay forever young? So we're going to talk about sleep health, sleep disorders, and sleep and heart disease in this case. So sleep health. So you will recall 2 years ago, we had Dr. McGowan come and give us captivating talk about sleep. And she mentioned that sleep was a vital sign. So this is something that we should be focusing on much more significantly as it relates to checking in of our patients. It's not significant just what their weight is and what their blood pressure is, but also understanding how much sleep they got the night before is critical. We need to value sleep because it is restorative, and the sleep disorders of insomnia and some of the other ones that we're going to cover can be very detrimental to the health. Additionally, people need sleep to get through their workday, their jobs, their childcare, and oftentimes people end up turning towards drugs to manage this. And it's also important to realize that a lot of the studies looking at pharmacologic therapy and sleep disorders in women show that the drugs differ compared to our male counterparts, and they may not necessarily provide us with the same benefits. So sleep patterns. If you look at this graph, you'll be able to see during the course of a night, the body is falling in and out of different sleep degrees. So the REM sleep that they have may come at different stages of the night and be different lengths of time, but it's generally known to be important to get this REM sleep. So REM stands for rapid eye movements. The functions of this amount of sleep are poorly understood at this time, but being studied extensively because they contribute to restorative sleep, revitalizing sleep, and reparative sleep. And those that do not have REM sleep are diagnosed with disorders such as obstructive sleep apnea and a variety of other pulmonary disease processes. So sleep apnea. There are 2 different categories of sleep apnea that we look for. One is central sleep apnea and the other is obstructive sleep apnea. The end result of both of them is hypoxia, so decreased oxygenation. Central sleep apnea has to do with how the diaphragm works, and if it's not working well, you're not taking in enough oxygen through the lungs. Obstructive sleep apnea is the one that we're a bit more familiar with. It has more to do with a soft palate and how it clamps down and makes it difficult for oxygenated oxygen to get into our system so that we can make some oxygenated blood. People that have sleep apnea generally have snoring, gasping for breath, fitful sleep, and daytime tiredness. So there are a lot of changes that occur in our body with sleep apnea. And so a lot of these have to do with different chemicals that get released in our system when we're undergoing these different disorders. So weight gain is one, increased blood pressure, increased cholesterol, an increase in blood sugar. So all of those things put together are bad for cardiovascular health. So certainly identifying sleep apnea as it relates to changes in your body is significant. How about changes in your heart specifically? So if you look at a heart, the normal heart that is pumping blood around your body, the left side is pumping blood through your body, the right side is pumping through your lungs. So over time, if you have a scenario where you don't have enough oxygen, then the right side of your heart will start to work overtime as it relates to getting more oxygen to the tissues and working harder. So it'll thicken and it'll start to dilate. And over time, you'll end up with this right ventricular failure where the right heart is ballooned out. it cannot squeeze well, and ultimately, these are patients that end up with degrees of congestive heart failure. So if we look at patients that have sleep disorders and cardiovascular disease, arrhythmias are a really significant problem as it relates to the hypoxia that patients get. So with hypoxia, as we know, comes structural heart disease issues. Additionally, comes the heart's desire to get more oxygen to the body. And so these arrhythmias start with rapid beats. So if you're diagnosed with something like atrial fibrillation, which is an arrhythmia of the heart, one of the initial workup tools is doing a sleep study. If you look at this chart, you will see the incidence of atrial fibrillation based on the presence or absence of obstructive sleep apnea is double in patients that have obstructive sleep apnea compared to people with no sleep apnea. So you can imagine a scenario where somebody has AFib diagnosed, but then works on managing their obstructive sleep apnea and will either lower their atrial fibrillation burden or perhaps even cure their issues related to their arrhythmia with treatment of their obstructive sleep apnea. And obstructive sleep apnea is not something that is just in older decades of life. There are interesting studies looking at women that are pregnant and sleep apnea. And if you assess a patient who is pregnant who has sleep apnea, you can see that their risks of cardiomyopathy, congestive heart failure, and in-hospital mortality are significantly elevated. So identifying these patients when they're pregnant as to whether they have obstructive sleep apnea and treating them will greatly reduce their likelihood of having an unfortunate event during their pregnancy. So in conclusion, sleep plays a key role in heart health. It is implicated with elevated blood pressures, arrhythmias such as atrial fibrillation and congestive heart failure. And it is not something that is just for our older patients. This is something that younger patients can have as well. So for our final case, case 5, we have a 50-year-old healthcare worker at St. John's. COVID is raging, and she wants to make sure that she stays as protective as reasonably possible. But she does have some reservations about the new COVID vaccine. She wants to live forever, but she doesn't want to harm herself by getting the vaccine. So in this talk, we're going to talk about COVID and heart disease, COVID treatment, and vaccination. So I know we have seen this chart many times over since March, but this is a distribution of COVID cases over the world. And you will see that the Americas as well as Europe have the highest levels as documented on this slide. If we just narrow down our focus to the United States, you can see that as of January 20th, the Southwest, Southern California, as well as the Southeast are having big pockets of COVID at this time, which is obviously quite concerning. And if we spotlight California just for the fun of the sad perspective, we can see our rates in almost every county are going up. It is extremely unfortunate as to what is going on in our hospitals, and there are 0 ICU beds, and based on the county data, it is considered to be widespread in all counties, almost all counties in California. So why is COVID significant for our patients with heart disease? Well, the statistics are not good as it relates to somebody who has heart disease. Now, we define heart disease as people with coronary artery disease, congestive heart failure, and or significant valvular heart disease. And if you have any of those conditions, your mortality rates associated with getting COVID are 10.5%. So that is basically double all of these other risk factors of disease and much more significant than if you had no risk factors at all. What I think is interesting as it relates to this graph is one would generally think that patients with cancer who are on immunosuppressive agents and or have low immunity would have a higher death rate than 5. But heart disease patients end up with double the death rate of cancer patients with COVID. So what can happen to your heart when you get COVID? Well, when you get the infection, there is this huge systemic inflammatory release. All the different cytokines are released into the system, and they can hit any organ system, including the heart. So with the heart, what you end up getting is an inflammation of the heart muscle, so that's myocarditis. You can end up with a stress cardiomyopathy where the heart doesn't squeeze normally. You can end up having a heart attack, and so that can be from plaque rupture associated with having some coronary artery disease, and or the clotting disorders that occur with having COVID, and you can block a heart artery with a clot. You can end up with congestive heart failure, cardiogenic shock, and ultimately you can end up with some cardiac arrhythmias that can lead to death. So the treatment options are ongoing and being researched extensively right now. Mostly what we utilize is supportive care. We want to relieve the patient's symptoms, manage their volume status. So if they're dehydrated, give them fluid. If they're in volume overload, try to get that fluid off so that they can breathe easier. We give them oxygen support, and also prone positioning is something that we utilize in the hospital quite significantly. In severe cases, we put patients on dexamethasone, which is an IV steroid treatment to lower the inflammation in the system. We also may need to provide ventilatory support, as well as extracorporeal membrane oxygenation, or ECMO. There are also experimental therapies that are ongoing. St. John's is participating in a lot of different research studies looking at the monoclonal antibody-based therapies, as well as different therapies like remdesivir. There are other ineffective therapies that had been used earlier in the pandemic that are not being used now. They're listed below, but those are not things that we are using currently on our patients. So if we segue into the vaccines for a second, there are two that are out right now. There's the Pfizer and the Moderna. They're both mRNA vaccines, and they both require 2 shots. So the Pfizer one gives you your second shot 3 weeks from your first. Approximately 2 weeks after your second shot, you have a 95% immunity to COVID. The Moderna shot, you get your second shot about 4 weeks after your first, and that will give you the same type of 95% immunity 2 weeks after that second shot. The side effects are considered to be minimal and generally felt to be related to your body's own immune response after you're getting the vaccine. So I get a lot of questions from patients about the vaccine, and one of the primary questions is, can I get COVID from getting the vaccine? And the answer is no. This is not a live virus. There are some people that do feel poorly afterwards, and they may be concerned that they had contracted COVID in that time with fevers, chills, malaise, nausea, vomiting. Generally, those symptoms go away within 24 hours. And clearly, if you had COVID, the symptoms don't go away within 24 hours. Additionally, I have some patients that are concerned about this mRNA technology, since it is the first vaccine using this technology. It is really not new technology. It's something that they have been working on for over 3 decades now. And interestingly, there was a lot of work with SARS and the MERS viruses back in 2006, but the vaccines were ultimately not completed at that time because they lost any financial support. So the irons were already in the fire as it relates to the mRNA vaccine. Was very interesting because this couple that are featured in Time magazine started the BioNTech company, and as soon as they were able to genetically sequence the virus, they were able to create a vaccine, partner with Pfizer back in March, and start animal trials as early as March, looking at the Pfizer vaccine using this mRNA technology. What is very interesting about this is to know that this is something that from a company that they have developed that was using this technology to combat cancer treatments. They can also use it for viral infections as well. This is similar technology that they're looking at for the Zika virus, Ebola, influenza, and also cancer therapies such as melanoma. So how much protection do you need after you get vaccinated? Well, this is a hot area of research because we are not sure. So once you're vaccinated, the concerns are that you will still be able to transmit the virus to other people that are not protected. So the mantra at this time is to still wear your mask, Still be as careful as you've been, but hopefully you will be protected against getting COVID, at least at a 95% likelihood. The other issue associated with this is there are talks about how long the immunity will last in your system, and the concept of having a repeat vaccine exists. It may be something similar to the flu shot, or something that you'll need to maintain adequate titers of your COVID antibodies within your system, and you may need to have a redo shot at some point. So in conclusion, COVID is a deadly disease, but it is even worse for our heart disease patients. We have been privy to the first vaccine of its kind, this mRNA vaccine, but it is not new technology. It's something that's been around for quite some time. And once you are vaccinated, you still need to stay safe and protect your family and your loved ones. So that is the end of my talk. I hope you learned a little something from these 5 cases today, and hopefully you'll have some take-home points so that you can be forever young and ask good questions when you go to the doctor's office. From the bottom of our hearts, we thank you so much for supporting our Women's Heart Symposium over the years. We cannot thank you enough for being part of today's activity.